I come from the land of Lyme disease as well, so I've seen a few interesting cases related to Lyme.
Yeah, I don't live there, so
Yeah.
you have more experience with it.
Yeah. Like I was just going to say, I've had a couple of patients who've had gotten Lyme disease who had EDS POTS, and they ended up having CRPS reaction to Lyme. So it was quite interesting. One patient actually became wheelchair bound after getting infected. So it does happen, but not as necessarily the cause of, some of these neuropathies that Jean was talking about. I'm going to specifically talk about POTS today, both not only in a general sense, but also related to EDS. And I think that you'll see some spillover into some things that Jean has already talked about. And we will, obviously, this is all a continuum, and more will be expanded upon as the talks go on this afternoon. So POTS is one aspect of my practice. I see kids who have it in its isolated form, and then I obviously have a substantial population of patients who have this in relationship to chronic diseases such as EDS, metabolic diseases, and the like. So POTS is actually has a very strict definition. This is the sort of minimum criteria that we have established over time. So it is defined as the presence of symptoms of orthostatic intolerance. So it's not just numbers, you actually have to have symptoms, and that's something that I get questions about all the time. The criteria is really an increase in heart rate of 30 points or more, or an absolute heart rate of over 120 beats per minute after standing less than 10 minutes or after head-up tilt table testing. There are some adolescent or younger patient criteria that include a higher heart rate response, 35 to 40 point increase. I think that sometimes is a bit controversial in my practice, especially when you have patients who clearly have orthostatic intolerance and maybe they don't reach that criteria when they're evaluated. It is not associated, POTS cannot be associated with prolonged bed rest or with the use of medications known to reduce vascular tone. And this also becomes very tricky when dealing with some of our chronic patients who get referred. They're already on certain antidepressants, things that Dr. Teasley mentioned that can lower blood pressure and potentially cause symptoms. So one of the most important things that I've learned in dealing with these patients, and certainly when you look at the criteria, the definition does not include criteria involving blood pressure. And certainly you can see a wide variability of postural blood pressure response in these patients. And we'll go into that a little bit more in terms of how we determine what a patient may or may not respond to for treatment. Probably a gross underestimate, since it's very underestimated and very underdiagnosed in our society, is probably greater than 500,000 people are affected by POTS in the US. At least 25% are unable to attend work or school full time. And it is frequently misdiagnosed as anxiety or depression. Conversion disorder comes up a lot, especially in our female patients. And the onset in many patients is often after an acute event, surgery. I hear mononucleosis. I have patients who've had concussions and different events that have happened to them. It is a bit different when you're talking about patients with Ehlers-Danlos or metabolic diseases that are more indolent, maybe chronic, progressive over a period of years. These patients in particular have pervasive symptoms of dysautonomia, again, bleeding over into some of the other topics that you're going to hear about today. So what we see is our vital sign changes that are pathologic and reflective of a paradoxical neural reflex. The end result is our cardiovascular symptoms, but in fact, it is a peripheral neuropathy that ends up affecting variety of systems in the body. It can occur in people of all ages, both healthy and chronically ill, and can occur either in a sitting or standing position. I think we've all up here had experiences with patients who have chronic disease states where syncope has occurred in the supine position, which in classic teaching we've told is very, very difficult to achieve. So this does, I think, surprise a lot of people when they encounter it. So the blood pressure drops are usually preceded by prodromal symptoms, so weakness, nausea, diaphoresis, and flushing, lightheadedness, and a sense of impending darkness or tunnel vision. Sometimes we see various descriptions, speckles in front of my eyes, tunnel vision, the shades coming down, all of these kind of descriptions we hear. This is followed by signs and symptoms of the blood pressure being affected. This includes tachycardia, pallor, the heart rate can actually slow down in some patients depending on the mechanism that is predominant, diaphoresis and pupillary constriction. And finally, we have decreased cerebral perfusion resulting in syncope, such as this unfortunate soldier here. Normal physiology, when we stand up, from the supine to upright position, about a liter of fluid, of venous blood, is shifted from the thorax to the lower extremities. And to preserve cerebral perfusion, there are baroreceptors in the carotid sinus and aortic arch that reduce their inhibitory control of the vasomotor center of the medulla. By virtue of this, sympathetic tone throughout the body is enhanced and parasympathetic tone is reduced. This theoretically increases vascular tone and increases cardiac contractility, which is a compensatory mechanism for the positional change. There are vasoactive substances which are released during this process, which are appropriate for this maneuver, but they don't overcompensate, which is the problem with POTS in many circumstances. Catecholamines and vasopressins are released to increase contractility, heart rate, and vascular resistance, and as a result, cerebral perfusion is maintained and nobody blacks out or has syncope. So what goes wrong in POTS? This is actually a bulldog that did faint. So we have many a species that suffer from this phenomenon. So people have tried to categorize POTS, and I think the main two that I think are applicable here are neuropathic POTS and hyperadrenergic POTS. There's some that's POTS of chronic disease, but in reality, neuropathic POTS and hyperadrenergic POTS sort of cover all of those types of categories that people try to, compartmentalize this disease state into. So neuropathic POTS, and this again, I think speaks to what Dr. Teasley was talking about, is a peripheral neuropathy that causes decreased vascular tone. There's impaired vasoconstriction that causes compensatory tachycardia. She also mentioned the pseudomotor axonal testing. There's abnormalities in that testing in both of these categories, and they do have particularly associated symptoms with either of them. Hyperadrenergic POTS has a demonstrable elevated standing norepinephrine levels, which are above and beyond what the normal response would be to a positional change. There's pronounced tachycardia and hypertension and hyperhidrosis, so again, abnormal sweating reflex. During the catecholamine state with initial sympathetic discharge, there's increased cardiac contractility. So the norepinephrine is released, and this actually affects the inotropy as well as the chronotropy of the heart. This, coupled with low ventricular volume from the fluid shifts down from the thorax to the lower extremities, triggers cardiac mechanoreceptors These are located in the base of both ventricles, especially in the inferior wall. The mechanoreceptors, paradoxically and or mistakenly misinterpret this response to be a high volume hypertensive state because it's actually feeling increased pressure within the myocardium, and this sets off a cascade of neurologic reflexes. This is really thought to be the pathologic step in the vasovagal response, and this has been confirmed with animal and human studies and has been termed what we call the basal gyrus reflex, although it's certainly something that we use talking about POTS, but we don't really bring this up with our patients because it's kind of an old term. The CNS response to increased parasympathetic output, and this causes bradycardia and vasodilatation as a response, and that's when patients faint. So you start off tachycardic and hypercontractile, and you end up bradycardic with a low blood pressure as a result. So in relationship to EDS, metabolic diseases, we have not only the cardiovascular effects, but many other not clearly autonomic symptoms, but certainly there's a very high association of these symptoms with the blood pressure and heart rate abnormalities we see with POTS. We have a high association with anxiety or depression in these patients. We have what we'll hear a lot about today, which is brain fog, which is mostly inability to concentrate for very long, feeling that you can't learn, you can't remember things that you just read. There's a variety of descriptions that patients use to describe what we call brain fog. Chronic fatigue. I think most of our patients are very tired for a number of reasons. I think not only from pain issues, sleep issues, but just having to deal with the chronic disease itself. Headaches, so this is a very sort of nebulous thing when patients come in. They say they have headaches. Some of the headaches are POTS related, just by virtue of having acute blood pressure reduction, you can trigger a headache response. So a lot of patients have postural headaches. They get up too fast, they feel dizzy, and then they have a headache for the next 2 hours. That happens in EDS patients. It happens in patients with no other diseases, except that they have a tendency to drop their blood pressure when they stand, as they get a severe headache afterwards. But some of them truly have migraine headaches, and this is something that, again, is a vascular-related issue, and so there's definitely a relationship there. Many of our patients have exercise intolerance. There's a number of reasons for that too. Either your joints hurt, your head hurts, or your POTS is so out of control that you're getting chest pain, or inappropriate tachycardia with exercise, and you're generally deconditioned. So there's a whole host of issues where exercise becomes a real challenge for these patients, and I think that's something that we always have to address. We want to address these multi-system issues so that patients can exercise, as we know that exercise is a very therapeutic treatment for POTS and a very important part of our treatment plan. And one thing that is interesting, and there's been a few papers written about this, and I'll just put this out there, is that dysautonomia patients' symptoms actually are increased in patients with autistic spectrum. So we have, a good number of patients who show up with autistic spectrum disorder, and they happen to have orthostatic intolerance. They happen to have, inappropriate tachycardia when they stand or do very mild exercise. And so it's something that is unrecognized, but autism and autistic spectrum does show up in a lot of our metabolic patients or other patients with chronic disease states. which are also associated with dysautonomia. So expanding the associated symptoms that we have with POTS, and certainly EDS as one of the chronic disease states where we see POTS active in. So visceral pain and dysmotility. We have about 40% of patients reported to have nausea associated with chronic nausea. 18% have diarrhea, 15% constipation, and another 15% with chronic abdominal pain. At least 9% have bladder symptoms, more or less, depending on their associated neurologic issues. And these are, I think, very, very commonly things that we hear from our patients. Chronic fatigue and insomnia, another very, very common complaint. This is really about half of our patients, at least, whether they have EDS or not. They're always very tired. They feel like they can't go to a full day of school. Their functional capacity is diminished in some way. Insomnia, sleep disturbances in 36%. This is from Journal of Clinical Sleep Medicine a couple years ago, and that's certainly something that we certainly struggle with. We have a lot of patients who just can't sleep. They just have a horrible time. They've tried every medication under the sun, maybe not Rohypnol, but but they have tried the melatonin and the tricyclics and the trazodone, and they just can't find an option that helps them. Headaches, as I mentioned, orthostatic headaches, and and certainly migraines. We also have not only, and this is a very triangular thing with EDS, as we know that Chiari-1 malformations have an association with EDS, but we certainly, just patients who don't have EDS, who just have Chiari-1, we know that they also have an association with increased incidence of postural tachycardia, whether they have joint hypermobility or not. So it's an interesting triangular relationship there. Okay, all right. So when we have patients who come in who have these symptoms, they've maybe passed out, and we get this patient who just chief complaint of syncope, and they come in and we have absolutely no idea how complicated their story is. We have a lot of patients who come in and their blood pressures are 80/50. It's a 15-year-old girl, and her heart rate goes up to 130 when she stands up. And oh, by the way, when I walk into the room, she's twisted up like a pretzel on the exam table. And a lot of these patients come to me first for their fainting, and they end up, I'm the one who identifies their EDS, and off we go to genetics and GI and all these places that they need to be seen. So taking a good history is really the best, starting place. I mean, and that's kind of basic for, I think, anybody with a medical degree to know. But I think we forget that in our crazy schedule, our time constraints, and I think that's something that gets lost in a lot of exam rooms, is that physicians don't listen, and they don't take the time to hear the entire story. And this includes a good review of systems. So it's not just, a focus, and that's very easy to do, especially in my clinic where, this is what I deal with, right? But of course that just can't happen when I have patients who come in with the host of symptoms that they're experiencing. We do orthostatic blood pressure and heart rate measurements. There's different ways to do this. We take at least 3 measurements, 2 of which should be in the upright position at different increments within a 10-minute period. I usually have my patients stand up for a minute, and then we take a blood pressure, and then we wait another 5 minutes. We take a blood pressure and heart rate. Some people say wait till 10 minutes. I find that very hard to do in a lot of my patients. Either they get bored and they start dancing, and that messes up our, we have very nice people to talk to in my clinic, but patients get bored. And then some patients are literally, they're weak. Not just because they're dizzy, but because their joints are painful. They're exhausted for some reason. Some of them are actually they can't walk around for very long without needing to get into a wheelchair. So we do have some limitations that we have to respect. But certainly we do our best to sort of assess the patient in this way. Then, of course, we do a physical examination, and we certainly look for a number of things. We look for a few patients of mine come in and they look like they've just gone to the ophthalmologist, and I say, "Are you okay? How many of me do you see, and do you see me clearly?" Because they really have hugely dilated pupils, and it's pretty dramatic, and it's really fun to show the residents and medical students this, because they're like, wow, how can they focus that way? But their pupils react normally, but they do have a baseline mydriasis. There's evidence of venous congestion in the extremities in some patients, so you see this sort of purpley, slightly congested, edematous looking lower extremity. Usually it's more common in the feet than the hands, but occasionally you'll see some hands that look that way. Hypermobile joints, certainly sometimes they walk in with chief complaint of this, and really they've got a connective tissue disorder that needs to be worked up. And then, more often than not, they don't really have anything specifically cardiac exam-wise. I would say that, unless they've got a really bad case of mitral valve prolapse, I don't hear a lot of abnormalities in the chest exam. But those are sort of hallmark things that I see commonly. So this is a test I don't particularly relish doing. I do this if a patient comes in with symptoms that cannot be explained by simple orthostatic measurements, or they have fainting episodes in very bizarre circumstances, and especially if they have no warning. Most of our patients have a prodrome that they can identify. They know it's coming, and tilt table testing usually has a great role in research and certainly testing treatments, and there's obviously many centers around the country. This is what they do. They sort of start a treatment, they tilt before, tilt after, and they put out a lot of great data. But in my practice, I am not routinely doing that, so I tend to not do this too often. But I will say I have a fair number of neurologists, that don't know anything about tilt table testing, and they will send me a 5-year-old who passed out because they were in the nail salon with the grandmother and they got overcome with the nail polish remover scent, and they passed out. Can you do a tilt table test on this patient? The answer to that is no. I don't think they realize what this is about.
I'm trainable, so I have learned that.
So it's something that I think people have to appreciate. I've had patients who I have done tilt table. All they did is cry the entire time. I felt like a horrible person. The patient is passively strapped to a bed with several belts, up to the chest and down. We put an IV in for fluid and medication access. We put a monitor on for blood pressure and heart rate, ECG monitoring. And then the room is made to be really warm and really dark and low noise level. And so this is not playtime. This is not, there's, poor patients, they sort of want to talk to you, and you're like, shh, can't do that. So there's that age limit at which becomes very inappropriate no matter what, for obvious reasons, since the parents don't come in either. The bed is tilted to 60 to 70 degrees, and then baseline monitoring in my practice has been for about 20 minutes. And then different people do different things in terms of provocative testing. I use isoprel. Some people use nitroglycerin. There's a number of agents that we can do to either to vasodilate somebody, and isoprel is one of them. That's very uncomfortable for patients. And we use isoprel in regular electrophysiology studies. The patient is somewhat awake. If the patient is sort of moderately sedated, that's the one thing that wakes them up, is the sensation of their heart pounding like crazy, and it's uncomfortable. So when they're strapped to a bed and their heart is racing and their blood pressure is slightly lower, it's a horrible feeling. Even if they don't feel dizzy at the moment, it's just uncomfortable. And so we started a low dose for about 5 or 10 minutes, and then we increase it at the last stage, and then we're done if the patient's made it that far. And so this is just a representation of a standard tilt table where the bed is tilted. There's a number of straps and kind of supports that we use for the upper body, but the legs are sort of, standing usually on a support at the end of the bed. The bottom here is a representation of a tilt table graphic report. So in the black is the heart rate response when the bed was tilted at this time point. This blue phase here is the blood pressure response, and the patient obviously had a tachycardic response to head up tilt, and then at some point 17, 18 minutes down the line, the patient became hypotensive, and sort of coincidentally, the blood pressure, the heart rate dropped as well. So you had a near syncopal, or at least pre-syncopal event here, if not fully syncopal event. But the blood pressure seemed to recover here. So this patient had, it's hard to know exactly what came first, but it did seem that there's potentially there's certainly a vasodepressor response, but there's sort of simultaneous bradycardic response as well. Anyway, that's what a tilt table accomplishes. I'll say that most of my patients do not need this. I have plenty of data to sort of look at in terms of their just orthostatic blood pressures and heart rates in my clinic to really make a determination that they have POTS indeed. They have symptoms of orthostatic intolerance, and there are treatment plans instituted based on that data. But sometimes this does come into play at certain times. So, management. We certainly like to start with conservative measures. And I always say to my patients, these are the fundamentals. If you don't get these right, anything I give you in the form of a pill, tablet, liquid, pharmacology of any sort, is not going to work as well if they work at all. Hydration is obviously the underlying importance for a lot of patients who have baseline low blood pressures. So I really say 80 to 100 ounces of fluid a day. General avoidance of caffeine, as I drank my coffee this morning. But caffeine's a diuretic, basically. So if you're having a lot of caffeine and you're really fluid dependent, you're kind of doing yourself a disservice if you're overdoing it. It gets a little complicated when you're more sensitive to vasoconstrictors, and the caffeine kind of helps you with that. So there's some patients or their headaches get better when they take, they get their espresso shot. So, we have to play negotiator here a little bit sometimes. Associated migraines and concentration issues, caffeine can be helpful, but you just have to be a little bit strategic with that. Sodium intake is important for some patients, some more than others. Some really don't need a whole lot of sodium, and I'll talk about those patients. But generally speaking, the patients who do need about 5 or 6 grams of sodium daily. Some even more, but those patients are at the extremes. But sometimes patients do need to take sodium supplements in addition to their diet, because at some point eating ramen noodles with extra salt on it just becomes nauseating. So a lot of patients just can't deal with that. So we have to find other ways of getting the salt into them. Dietary habits, no skipping meals. In fact, small frequent meals are usually the way to go to avoid some of the, not only the POTS is addressed, but some of the GI issues are sensitive to those patterns. We don't want the blood to pool in your splanchnic system. That's not where it belongs. We want it in your central circulation, getting to your brain, getting to important organs that avoid you getting dizzy and experiencing other symptoms. And high carbohydrate meals are also felt, I think, because it does dilate the splanchnic vascular bed. But high carbohydrate meals have been known to exacerbate POTS and symptoms. So we want a balanced diet. We want a little protein, a little carbohydrates, a little fat, depending on obviously other factors related to some of the comorbid GI issues. Sleep, we've talked about sleep. Restorative sleep. Exercise, we really want people to get there. Well, sometimes we start in a very complicated place where exercise is a very big challenge for some of our patients, and we understand that. So the goal is really to get things, we help them so they can help themselves, is kind of how I view it. So we can get you in a place where patients can exercise, can be more active, and that sort of starts a positive cycle of you exercise more, your POTS get better, and so you can exercise more. So we have certainly used exercise in a positive way to get patients even off some of their medications. Resistance training, within limits, related to, especially with EDS patients, you have to be a little bit judicious with that, but water and swimming exercises do provide some resistance, and it's very gentle on joints, but it also improves muscle tone, and that improved muscle tone improves support for vascular tone, and that's something that I find very, very useful. Stress management. So I can have a patient who's beautifully controlled, and then they don't sleep, don't eat, don't properly take care of themselves during their final exams, and then they get out of a car one day and they pass out on the parking lot. So patients like yours who are busy teenagers or young adults who are trying to go to school, they have to grow up a little bit faster, and they have to realize that they can't pull all-nighters, they can't cram for exams. They can't stress their bodies in that very uneven way. So this is just, unfortunately, a little lecture I have to give to some of my teenagers for that purpose. And then we have to manage the provocative symptoms, pain, migraines, GI distress, preventing adequate nutrition, and then hormonal dysregulation, which is a big pet peeve of mine. Because so many people have that problem, and so that's where we get into this, where even if we do all of those wonderful things, some of our patients only wish they could feel this graceful when they were dizzy, and we need to use pharmacologic means of management. So a lot of drugs are studied out there, and they've all sort of said, well, it could be useful. They're chosen based on the pathophysiology thought to be involved. And the overwhelming majority of the agents came into popular use based on pretty small studies without controls and have relatively short-term follow-up. And this is a deficiency in the research that we are at the mercy of at this point. Anecdotal reports of success are certainly out there for many of these agents, but we also have to struggle with off-label use of medications, and I think I'll talk about a couple agents that we have difficulty with because of something that Dr. Teasley mentioned, which is insurance and the financial factors. So one of the very popular things that we use to treat POTS is our beta blockers. These agents are thought to block the early catecholamine-induced inotropy in the presence of low ventricular filling and decrease the stimulation of the mechanoreceptors, thus blocking the neurologic response to progress to hypotension. Probably the most studied agent, although it's only been introduced as treatment in 1989. Some data show conflicting results. The highest benefit, and this certainly is reflected in my practice, the highest benefit is shown in patients with a positive upright tilt table test after isoproterenol provocation. And this reflects a direct antagonism to the catecholamine effect of the isoproterenol. In patients not having the tilt table testing, the best response to beta blockers in my practice have had heart rate increases at greater or equal to 30 points with orthostatic testing and normal to borderline hypertensive postural blood pressure responses. So it speaks to the variable blood pressure responses you get to a POTS evaluation. The patients who I see who respond the best to beta blockers really do have hypertension when they stand up and with a corresponding tachycardia. And these patients really do very, very well on beta blockers, and it is a first-line treatment straight off the bat for me when I see that. We would consider using beta blockers too, especially if we have comorbid migraines and anxiety states. So beta blockers have been used for years for performance anxiety. They do have a little bit of a calming effect, and there have been reports that or some theory that maybe they actually help sleep. I have not had much effect with that, and I think that in fact, if you use a non-selective beta blocker in young patients, they often have sleep disturbances. So I have a lot of patients with vivid dreams and nightmares if you give them a non-selective beta blocker. There are many, many beta blockers out there. Metoprolol, atenolol, propranolol, nadolol, and my favorite, betaxolol, are out there for use. Propranolol is interesting. This has been studied probably the most out of all of them. There's some theory that this would be very effective because it crosses the blood-brain barrier and affects central norepinephrine release. I haven't really felt that to be very well substantiated, and I haven't really had patients who've have improved more on a propranolol regimen versus something a little bit more cardioselective or beta-1 selective. I love betaxolol because it's a once-a-day medication. It's very safe for my asthma patients, so patients who have asthma. So that's a huge advantage. And it's a long-acting, once-a-day medication you can give at night and really help patients when they get up in the morning. So for patients who have bad morning symptoms, it's a great agent because it lasts through the entire night. Florinef, this is a medication that people throw at anybody who has POTS, okay? And not everybody should have Florinef, especially the ones that I just described who have a hypertensive response to standing, because they'll just get more hypertensive. It's a mineralocorticoid analog. It sort of mimics the effect of aldosterone and pulling in sodium and water from the distal tubules. We use it also in patients with adrenal insufficiency. And so it sucks back in the sodium ions and wastes potassium ions, so patients can have low potassium at higher doses of this medication. The low dose fludrocortisone doses have powerful mineralocorticoid effects, and they minimize the glucocorticoid effects. So we usually start at 0.1 milligrams PO daily, and then we can increase that to twice a day. I don't really go beyond this dosing schedule. I find that patients start having glucocorticoid or prednisone-like effects when you get higher dosing, and it makes them moody. And I've just had a couple patients that taught me that lesson, and I don't need to reinvent the wheel there. This is really most effective in patients with baseline low blood pressures. So we're talking about systolic blood pressures, at most 105, usually lower, especially when they drop with positional changes and a corresponding increase in their heart rate. Usually the patient who's on this has failed to have signs of increased plasma volume despite salt supplementation. So we've tried some of these non-conservative measures and they've failed. The side effects, which I'm sure a lot of you are familiar with, are headaches, swelling of the extremities, low potassium, hyperglycemia, and increased sweating, which a couple of my patients have had. Midodrine is another very common medication that we use, oftentimes in combination with another medication. This is an oral vasopressor with a short half-life, so it's inconvenient for that purpose, but it's also very convenient for that purpose as well. You have to take it 3 to 4 times a day for a sustained effect. Some people have taken it more often than that. The effects only last about 4 hours, and you do better on it if your volume status is optimized, for sure. So it directly impacts the upright blood pressure with a secondary effect on the heart rate. But you can get supine hypertension. Certainly we say no dose is given 3 hours before bed. However, I have patients who at bedtime their blood pressures are 70 over 35. You know what? They're probably not going to get supine hypertension if you give them a little Midodrine before they go to sleep and they're dizzy. You can get some scalp paresthesias, often diminish after a few weeks of use, and then you get some goosebumps and other things, but certainly the supine hypertension is the big one. Some patients do get some headaches with it. This is best given in patients with evidence of neurogenic POTS and poor vascular tone. They usually flush in hot environments, so they need that vasoconstrictive effect to control that. And the nice thing about the short-acting nature of this drug is that you do have some flexibility in the dosing schedule, so you can give a PRN dose due to short-acting properties. If it's it's summertime and it's 100 degrees and they usually take it 3 times a day and they need to take a 4th dose because it's just wearing off more quickly in a hot environment, then you can do that. And if you have a side effect from it, you can always stop it. It's an easy thing to sort of put on and take away without a withdrawal effect or anything of that nature that could restrict your use of it. So Pyridostigmine or Mestinon is an acetylcholinesterase inhibitor. It inhibits the degradation of the neurotransmitter acetylcholine. We use this in patients with myasthenia gravis, which is a neuromuscular disease as well. It's been used in POTS with a statistically significant improvement in heart rate and symptom burden in a small series of 17 patients published in Circulation in 2005. And a larger study in PACE had 203 patients with POTS, showed about 43% of that total pool of patients had improved symptoms of orthostatic intolerance, including fatigue, palpitations, and pre-syncope. I would say that this drug is something I use second or third line. I think that I do not have a 43% symptom improvement rate. I have more of a 25 to 30% symptom improvement rate. Some of the patients can't take this because it does cause GI distress. So a lot of people get diarrhea, upset stomach, cramping, that kind of thing. That can help some patients who are constipated at baseline, but sometimes this is something that restricts the use of this. We also use it in patients who have significant brain fog. We find that their energy and their concentration can improve with that. And that's been successful in a few of my patients. But it is something where a lot of patients take it and they're like, nothing happened to me. It was completely the same. So I don't use it routinely unless we're kind of running out of options with the beta blocker Florinef Midodrine route. I'll bring up stimulants. Same kind of thing with Midodrine. They have similar vasoconstrictive effects, although they're a little bit more mixed in terms of their effects on the heart rate as well. So you can get a little bit of a elevated blood pressure effect, but the heart rate can go up too. And I see quite a few patients who are just taking stimulants who come to see me where the stimulant raise their heart rate to 135 beats per minute, and they're sitting there on the table and they're like, what's wrong with me? I feel fine. But their heart rate's 135, 140. So it can be pretty dramatic. So you have to be very careful about stimulants. The added benefit of using these is because the patients have brain fog, we really can have improved energy, concentration with these medications and can really make a big difference in school performance. The negative effect on appetite could be an issue, especially patients with coincident GI issues. So you have to be a little bit aware that it could compromise somebody's nutrition. Ritalin, Adderall, and Concerta are all used in various forms. Ritalin can be very short-acting, so we use it a lot in palliative care. So patients who have a chronic disease, they want to go to a birthday party, they want a 4-hour effect, they take a short-acting Ritalin and go. Adderall, Concerta are a little bit longer acting depending on what form you use. But it's something that we do look at now as an option for these patients. So SSRIs, these are obviously antidepressants. Through the years, we've noted that depressed patients with vasovagal syncope had substantial improvement of their syncope after SSRI treatment. Now, why is that? Is that product of the drug or because they just overall felt better and so didn't have sort of the physical symptoms of depression? However, in animal models, they have been shown to reduce CNS sympathetic activity and actually cause hypotension and bradycardia. So some patients who have a predominant tachycardia as a manifestation of their POTS may benefit from these agents. There also may be suppression of the baroreceptor reflex, which also would tend to decrease the heart rate. And it's theorized that SSRIs blunt the cardiovascular response to changing serotonin levels by causing downregulation of receptors. So a few of these have been shown to improve symptoms in non-depressed patients in case control studies. Newer agents like Cymbalta are under investigation. They also have effects on chronic pain. So a lot of patients are taking Cymbalta to deal with neuropathic pain in other areas, as well as deal with their POTS. And it's generally one of the least studied agents in this condition, and it is an off-label use still. So like I said, it's still used as about a third-line agents in pure POTS, but in chronic pain conditions, it may be used sooner, and some patients are already on them by the time I see them in clinic. I'll just mention a couple other medications that have been somewhat useful in some of my POTS patients. Clonidine is one of them. I think we mentioned that before in terms of not only helping sleep, but also it does reduce anxiety in a lot of patients. And if anxiety is a predominant factor in triggering POTS symptoms, it really is quite helpful. But it is sedating if you take it during the day. So some patients become very sleepy on it and they can't tolerate it. But it is something that we do use. Octreotide is another one of them. I mentioned serotonin. This is also a serotonin interacting medication. Octreotide is a subcutaneous injection. So that bothers some people, but it is also, again, an off-label use. So insurance companies really do not pay for that. And I don't believe I have any current patients on octreotide for this. So I'll talk about the influence of hormones because I think so many of the female patients that we have really suffer from this. So irregular and painful menses are incredibly common in females with POTS. And additional complications are seen in female patients with Ehlers-Danlos syndrome and other chronic metabolic or other diseases. There's a pattern of worsening symptoms and dizziness and orthostatic intolerance with menses and breakthrough bleeding. So if they're already on something and they're having breakthrough bleeding, the same problems occur. So estrogens in particular have effects on the renin-angiotensin system. They're somewhat they can be diuretic, they can have effects on the vascular system, and they have a vascular relaxing aspect to them at times. Progesterone in particular is a very potent smooth muscle relaxant, and it is a natural diuretic, so patients do lose what fluids they are taking in sometimes when you have hormonal imbalances. So a survey at Vanderbilt, their autonomic dysfunction center, really found that even patients who don't have POTS, so to speak, have problems when they menstruate. So the top line here. So the scale is really, here's the phase of menstruation here, so menstrual, follicular, mid-luteal, and late luteal stages. And then there's a sort of arbitrary scale. It really doesn't mean much except that what this means is that the POTS patients up here had a higher score of lightheadedness than during their menses than the control group, but generally speaking, the control group still felt a little bit more lightheaded during their menses than they did when they weren't bleeding, but the POTS patients had significantly more severe symptoms during those times. So we definitely know that patients with POTS have a tremendously worse time controlling their hormones. We also know that patients with POTS seem to have more sort of associated GYN issues than patients who do not have POTS. So they have, more issues with dysfunctional uterine bleeding, more endometriosis, more incidence of fibroids, more galactorrhea, everything else is, and then ovarian cysts. So this is something that why I like to send my patients with POTS who are having issues with their periods to a GYN who know what they're doing to sort of make sure that there's no other problems that are undetected up to that point. So the goals of doing that obviously are to rule out underlying GYN pathology. We want to work with them to regulate hormonal fluctuations causing symptoms, including dizziness, pain, nausea, migraines, etc. I have a number of patients who, when on their menses, the muscle relaxing properties of progesterone probably relaxes the musculature in the pelvic area. And we have more and more patients saying that their hips are are more painful during their periods. They have actually more joint pain. So there's some quite interesting things that go on that I hear about when related to young women who are having dysfunctional bleeding. The options for treatment usually include a monophasic oral contraceptive, where some patients just take that and skip the placebos. There's the 3-month cycle oral contraceptive, but sometimes that can be expensive, and these are not generic yet. Depo-Provera and Depo-Provera plus a progesterone supplement like Agestin to reduce breakthrough bleeding. And then finally, I'll bring up erythropoietin in this setting. It's used as a drug to obviously augment red blood cell count and treat anemia. Again, it's a subcutaneously injected drug, and it has been found, incidentally, to be a potent vasoconstrictor in some patients because of some associated hypertension that they found in chronic renal disease where they were treating the patient's anemia, and they acutely became more hypertensive unrelated to their renal problems. We really only recommend this in severely debilitated patients because it is off-label and not covered by insurance plan. It's really an act of desperation. There's definitely a risk of overshooting and creating hypertension. And then there's a risk of thrombosis and stroke if you have built the hematocrit up to over 50%. So you really have to be closely monitored to make sure that you're not causing sludging and problems with too high a hematocrit. So the overall goals of management for POTS is really get the day-to-day life habits solidified as much as possible. Use your colleagues, your subspecialists that you work with to sort of help work together and get the headaches and the neuropathic pain and the GI issues and all the rest, under control so the patients can have the best quality of life possible. Use the orthostatic responses in the outpatient setting and items in the medical history to rule in or rule out potential pharmacologic therapies. One patient, I'll just say, told me that the only way she felt good was if she went out in the snow without a coat and did snow angels and covered herself. That was the only time she didn't feel dizzy. And so that told me right there she needed Midodrine. And that's the one drug that worked for her. So, these kind of funny stories that give you the clue. And then understand and be upfront with patients that your first agent may be A, the wrong choice, and B, a partial solution due to some of the multifactorial pathways causing POTS. So some patients will need something that brings down the heart rate as a predominant effect, and then some patients will need that plus something that raises the blood pressure a bit as well. Patience is a virtue in this situation. There's a lot of trial and error, but we use our best judgment. And then be aware of other medical conditions which might influence POTS and point your patients in the right directions, meaning give them useful and good referrals to people like Dr. Teasley. So I just want to thank you for coming, and I'll answer a few questions, I guess, if we have time. So that's